Yeah, we feel the pressure now.
Good.
Big expectations.
Good.
Yeah. We've collected some questions
Good.
from the audience during this session today on the cellular phone, so it was probably the reason why you didn't get as many questions you wanted. We took them all.
I'm okay. I'm okay.
Yeah.
As far as I have got it, the GPM model is less extensive. It's not that intensive. You don't meet the person that often. The ingredients in the therapy is not that many. It's in specialized treatment. But when I saw your files here, you kind of involve family work, sometimes medications, psychoeducational stuff. So in my head, this general model started to look a little bit like the specialized model.
Yeah. Well, the difference is that none of these things are prescribed. That is, they're flexible, and a single person can do them themselves. That is, if you can involve a borderline patient in a group, it may be a group you lead, which is okay, or maybe any other kind of group like an AA group, for instance, or even encourage them to be participants in a church group. But, you know, that's an example of something that doesn't depend upon bringing in an independent group therapist. That doesn't mean if you have an independent group therapist, that's not a plus. You can do that. It's not something that, as with MBT and DBT, is hardwired into it, where you have to have another professional who you are in regular contact with and who has specialized training to run a group that is specifically molded to the same thing you're doing in the individual therapy. So that becomes logistically very difficult. To find people who are trained in the same model and who will live in the same area. Just the logistics, the feasibility of those models make them very difficult to implement outside of clinics. And they're even people with a lot more training than GPM requires.
There's a lot of people here today that are in private practice.
Yes.
Can you recommend this model to them?
Oh, yes. No, this would be actually more designed for people in private practice, office practice. And the message is that you don't have to be a specialist. And most of your patients will do all right. You need to be flexible and pragmatic. And if you can add a group, per se, that's great. You should definitely involve the family, not be, there's a generation of people and different training programs where they say if you're going to do individual therapy, then you shouldn't meet with the family, or that's just not reasonable within a GPM model. It might work someplace with some patients, but it's not a generalist model. This is where people who want to do well, responsibly, and in a pragmatic way that's reasonable for the vast majority of borderline patients. That's where it starts, and that's where it differs. You don't need a long-term supervision, ongoing supervision, and extensive training to do this. It's basically good sense.
There's one more question regarding severity. And you said that this GPM model could be used for everybody, and then those who don't succeed, they could be referred to some specialized treatment. But
yes,
is there some guidelines perhaps that guide you to kind of refer people to the specialized treatment at once? So, so you think that this model might be a little too narrow, perhaps?
Well, that's not an easy question to answer. If you have a patient who comes with having already failed in other treatments, then I would think that something more than GPM might be indicated. But even there, you'd want to take a look at what went on in the previous treatment, because so many borderline patients are given treatments which are harmful that just being sort of reasonable is a big step forward. So I wouldn't necessarily go from previous treatment failures. If somebody's had previous treatment failures by able people, then I would think about something specialist, more intensive treatments.
Yeah, you mentioned the McMain study
Yes.
where you compared this GPM model with DBT. And I was wondering about if you have any thoughts about the effects to the therapist effects. I understand that these were clinicians that were having approximately 5 years
Yes.
of experience and
Yes.
with an interest in working with these patients.
Yes.
Can you say something more about the
Yeah.
therapist
Yeah,
effects?
no, that's a very good point. For those of you who didn't understand this, that in the empirical study that was done in Canada, the DBT was arm of the study was under the direction of Shirley McMain, a very senior DBT expert and trainer, who's also the principal investigator. And the general psychiatric arm was done under the oversight of Paul McMain, a senior psychiatrist who was a co-investigator there. And they had some weekly meetings with him, and they were self-selected in the sense that they were average 5 years of experience and wanted to work with borderline patients. They were experienced already. So this was not just taking people off the street. And so in both instances, you have both sides of the equation are loaded towards getting more skilled than you're going to get off the streets. That is, if you go out and get the person who says they do DBT therapy and they do it sort of without adherence, and they don't have the weekly meetings, and they you're not going to get the same quality product. And it's the same is true of the good psychiatric management. These are not people who are just picked up off the street. They're people who wanted to do the study and had some ongoing supervision. So generalizing from that to every person can't be done. These other studies similarly had people who every one of these research projects has clinicians who self-select. So that it's hard to generalize from it, but the idea was in all cases, they were less intensive treatment by people who had not previously received extensive training to get adherent. They were brought in and got sort of ad hoc supervision during the course of the treatment. So it's less expensive with less training and thus more generalizable. When people say, well, does that mean that anybody can treat borderline patients? No. The fact that these people self-select to do this is a big factor. People self-select to work with borderline patients because they feel some affinity for this work, some comfort with this work, and have felt like they have some skill with this population. So it's probably still true in an audience like this, you all self-selected by coming here. So the chances of your being effective with borderline patients is greatly elevated just by virtue of the interest you're showing in the subject. The people who don't like working with borderline patients are unlikely to be transformed by a GPM model or any other model. And the people, even people who like working with borderline patients, sometimes are pretty bad with them. So, you know, it's despite all the training in the world.
I just want to give you a compliment with the regression model you've shown, where borderline persons take contact with health professionals on a better way as far as they go down the ladder, so to speak.
Yeah.
Yeah, it makes a lot of sense. It's easy to find this pathology is doing that.
Yeah, good.
And that kind of gives you the sense that you have to do something with the way they make contact, to respond to them quite early before they go all the way then. And you mentioned availability and crisis plan and all that stuff.
Yes.
So that kind of reminds the clinicians that how important that is before they go, so to speak, in the basement.
Yeah. Thank you. I have nothing to add.
I had a question actually to that model. In the top of the model, it said something about dependent and idealizing, was it? Or?
Yes, idealizing.
Yeah, and that is sort of the most well-functioning and wanted modus and baseline for these patients. So that's where you want to be.
That's what happens.
In a way.
If you're a kindly person and you don't leave the room, you know, you're going to be wonderful. Especially if you don't say too much of an unpleasant nature, you're going to be wonderful. Now, when you say that's the highest level, that's the level at which they are most apt to be collaborative and aren't apt to get in trouble. But they are still, even when they're looking that way, quite dysfunctional because their functioning is so context dependent. It's unrealistic for anybody to think that they're going to forever and always be surrounded by supportive others who have nothing other to do than to pay attention to them. That's where the psychopathology is, how dependent they are on that particular and it isn't you, sadly. It's not you, it's them. That, when we all start out in this and the patient says, nobody else understands me the way you do, you think, oh God, I'm gifted. I didn't know what I was doing, but I have some inherent gifts I did not know about. So this puts it in a context. It helps you understand that it's really not that you're gifted. You're gifted if you understand that it isn't you. I mean, that's what makes you a professional as opposed to just an ordinary person.
A little question about implementation of this model. You've seen the map about Norway, you know how far where we live. And, we are trying to get the primary care up and going,
Yes.
And a lot of resources have been put down there. And the so-called district psychiatric center, which is kind of specialized treatment, are now implementing the specialized models. That's a kind of politics now.
I think that's a mistake.
Yeah. So do you think this is perhaps the time for the primary care to embrace this?
Yeah, yes, absolutely.
You do?
Oh, absolutely.
Okay.
No, absolutely. It's true, my institution, we have 3 specialty programs for treating borderline patients. Our residency training program has sort of adopted trying to teach residents DBT because they ought to do something, but it's not well suited for residents. It's much too complicated. Very few of them are going to go on to become primary treaters for borderline personality disorder. What they need, what primary care people need, is something that is simpler to learn and more commonsensical. They don't need to learn a new language and have a book this big, and it's just not going to happen. It can't happen. And as long as public health care is adopting this thing, it's just going to run into obstacles which you can't overcome. You cannot provide that intensive treatment for that many people. So what you can do is get less intensive models, which may not be as great, but are good enough for the majority of people. And that, from a public health point of view, is where treatment should begin. And training programs should adopt this. Let me put a word in here that the last couple of years, we have done trainers workshops, 2 or 3 day workshops where people who have responsibility for training others, primarily psychiatric residents, have sent 2 or at most 3 people from their faculty to come for 2 to 3 days with us so that they can go back and implement changes in the training programs at their institutions. And if any of you work in settings where your institution would be receptive to implementing a training program on GPM, the next one we're going to do is going to be in Chicago at Northwestern in May, and then next September or October in Baltimore at Shepherd Pratt Hospital. These are opportunities where faculty who have some responsibility for training others can come with the idea that they'll go home with the tools for training other people and how to shape a curriculum in their institution, their training institution. And so anybody who's in that situation and would welcome that, give me your name and address, and I'll follow up, because we're trying to. The first 2 of these was really by invitation to institutions in New England. We were quite overwhelmed by the fact that everybody invited wanted to come. And now we're moved to the Midwest and the Mid-Atlantic states, but we have had people who have come from other countries to these, and they find them very useful, and certainly anybody from Norway would be doubly welcome. So.
One last question, probably. About the duration of therapy. You say that the length of therapy is often short periodically and non-intensive, and that is most often good enough
Yes.
for borderline patients. And I was a bit baffled because I am of the experience that it takes time to establish a trustful collaboration and relationship, therapeutic
Yes.
relationship.
Yes,
Which,
it's true. It does take time to develop a trustful relationship, but that's not the goal of therapy.
That's not.
That's not the goal of therapy. The goal of GPM is to help people get into and facilitate their development of trusting relationships any place and every place in the world. So it doesn't depend on you. That's the model about which I've grown up with. They learn to trust you, then it generalizes in their ability to trust others. It's still a good model. But borderline patients, one of the processes by which that occurs is that they come to see you, you're helpful, they say, I don't want to come, you examine why, you don't fight it, you make yourself available, they'll come back when they want to see you. You become a resource for managing their life. That's not the same as creating a relationship which is going to change their life. You become somebody who is available as needed. And sometimes out of that experience, even intermittent, briefer episodes, they can learn to trust you And it becomes a reason to generalize there, that they're non-exploited, you're not pushing them to do things they don't want to do, and you're helpful when they do see you. It's not common. Yeah. And you can get in big trouble when you insist with borderline patients that they really need to see you, because otherwise they're not going to develop that relationship they need, the capacity to have relationships they want. That's a model. It can happen. But in the GPM, that's occasional and it's great. But your real hope is that you'll facilitate their getting into those relationships out in the real world. Somebody stable, sort of obsessive compulsive, very loyal, careful, you know, not very emotional. A Norwegian.
You should wait to later when we have some beer under our vest. Things might change. Well, thank you very much, John,
Thank
for
you.
your opening.
Hey.
Yeah.
I think, John, this has been a very important day for us to hear this model with knowledge and respect for the patients. So that's a fabulous message that you have, I think.
Yeah, thank you very much.
And here I have some selbevotter. That's a special Norwegian heritage for your hands when they get cold. I heard that you have some very cold time in the US, but we have too warm here, so we have too much of selbevotter here in Norway. So I think you deserve this. Thank you very much.
Thank you very much.
Okay.
Great.
Well, thank you.